Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician, in continuity with the previous lectures on CNS examination or neurology examination. In this particular lecture, I will be showing you some clips, video clips which I have got from YouTube's, and I'm very thankful to the person who has uploaded those video clips. I'm using for an educative purpose only. So this video clip will show you how the reflexes are elicited. There will be some clip on Clonus, some clip on Hoffman sign, etc. So let us go through that. So this is on elicitation of a deep tendon reflex, or we call motor reflex. Now this will be the first clip. In between I will be explaining you.
So this part of the video is going to be demonstrating how
She is going to demonstrate all different reflexes. So what she is doing, she is first introducing, she is explaining the procedure, what she is going to do, she is taking permission.
Otherwise you won't get a reflex from it. So we want to make sure that we test them in both upper and lower extremities, and we test them bilaterally. So we're going to start with the upper extremity and the biceps reflex. So this is a reflex on the biceps tendon. And what we want to do for this one is, again, the patient's arm is to be...
This is bicep jerk. You can see that this is elicited in a sitting posture. She is putting the thumb on a bicep tendon and elbow is at right angle. And sharp jerk is given by this hammer. By and large, now the use of this hammer, as far as possible, should be avoided. You can see the contraction at elbow. So there is a slight flexion, and you will have a contraction of bicep. You can see the movement at elbow. This is normal. You can see the contraction of bicep muscle and movement. Now she is eliciting tricep jerk. So she is supporting the elbow, putting the hand in a position which we call 90-degree angle. She is supporting by the hand and she is giving a sharp jerk on tricep tendon, and you can see the movement at elbow, that is extension and contraction of tricep muscle. Again, same thing is elicited here. You can see that there is a movement of hand at elbow and contraction of tricep muscle. Now she is eliciting the knee jerk. She is giving a sharp jerk. You can see the extension at knee on patellar tendon. You can clearly see a nice extension at elbow. At knee. And simultaneously contraction of quadriceps. Now she is going to elicit ankle jerk. Little difficult, but can be elicited as far as possible. Always take it in a supine posture. So little dorsiflexion and jerk is given on the tendo achilles. You can see the plantar flexion at ankle. Same, plantar flexion at ankle due to contraction of calf muscle.
So the next reflex we want to do is the plantar response reflex, which is also referred to as the Binsky. So what you're going to have to do, the patient do, is if you could move back on the table a little bit for me, I'm going to pull out the footrest.
Now she is going to elicit plantar reflex.
Run an object relatively firmly across the dorsal aspect.
A blunt object is used.
Now you want to make sure you use something clean.
Detail is explained.
So that you're not, again, transferring things back and forth between patients. Because this is a relatively firm pressure. So we generally use a Newton weight for that. What you're going to do is on the sole of the foot.
This is a blunt object, that is a tongue depressor.
And towards the midline. You want to do it
and this is where you stimulate right from the heel towards the small toe and then towards the great toe. One single stroke. And you hold it at ankle and look at the flexion of great toe and adduction and flexion of all fingers. One single stroke.
the plantar surface of the foot. So toes down going is the normal response. If when I did that motion, his toes pointed upwards, that would be upward going toes, or an abnormal response to the Babinski.
Now, he will be demonstrating again all the reflexes. He is using a clinical hammer. He is explaining what he is going to do. He is explaining to the person and then taking a permission. Now, first he is demonstrating superficial reflexes by using a blunt object. This is abdominal reflex. From lateral to medial, you stroke the skin from lateral to medial and in the diagonal. And you look at the contraction of abdominal muscle. If they are present, normal. If it is absent on one side, that is very frequently because of pyramidal damage or damage to the reflex arc at the local level in lower motor neuron. And in upper motor neuron, it will be absent on the side of the pyramidal tract damage. He is explaining all those mechanisms, in which condition it will be absent. Now he is using a blunt object to elicit, that is the key, to elicit the plantar reflex. He is explaining what he is going to do. And then he is holding at ankle and striking the foot from heel towards the great toe and from there towards the small toe. And you have to observe the plantar flexion of the great toe and adduction of all toes. Normal person, there will be all adduction of the toes, plantar flexion of great toe, plantar flexion of all toes, plantar flexion of foot, and simultaneously there will be a withdrawal response. Means flexion at knee, flexion at hip, and you will also have contraction of tensor fasciae lata. And in case of upper motor neuron, you will have a plantar extensor. All toes will undergo adduction. Great toe will be again dorsiflexion. And there will be plantar extension or dorsiflexion we call. Plus withdrawal response. So it's explaining what will be the thing you will get along with plantar reflex. That will be part of the withdrawal will be also seen. And you should be able to differentiate between upper motor neuron and lower motor neuron. In lower motor neuron, plantar reflex will be absent, and in upper motor neuron, you will have a plantar extensor or plantar, that is foot, will undergo dorsiflexion with abduction of the toes and plantar great toe. This is he is demonstrating Oppenheim. This is Gordon's. This is squeezing tendo achilles. You can flick the lateral malleolus. These are all the different technology to demonstrate again plantar extensor in upper motor neuron. Flicking the small toe or tapping on the small toe. or you prick over the dorsal surface of the foot also will produce the great toe into extension. All that suggests upper motor neuron damage. Little difficult to elicit, but sometimes it is very useful. These tests are very useful. And you can look for tensor fascial lata contraction. That will be present in upper motor neuron. Now he is eliciting the dip tendon reflex in upper limb. This is the best position you can give. Right angle, that is at elbow 90 degree. Now he is giving a tap on the tricep tendon. And you can look at the contraction of tricep muscle and extension at elbow. And if it is not elicitable, you can do reinforcement. And you compare right with left. In bicep, you put a finger or thumb on the bicep tendon and give a jerk. And look for the contraction of bicep muscle and flexion at elbow. Now this is brachioradialis. Above the styloid process, just above the styloid process, you can give a direct tap. And you look at the flexion at elbow and movement, contraction of brachioradialis muscle. This is finger flexion. This is finger flexion. In upper motor neuron, it will be exaggerated. This is Hoffman test. It will be positive or it will be exaggerated in case of upper motor neuron. You will get flexion of the thumb and flexion of the index finger. That is Hoffman test. There is also another test called as a Wattenberg test. This is knee jerk. In supine posture based method, you can just give a tap on the patellar tendon, look at the contraction of quadriceps and extension at knee. You can see the contraction of quadriceps and little extension at knee. You can see the movement at knee and contraction of quadriceps. Now this is ankle. This is the best method of eliciting. You can put a knee and you can see at the knee it is 90 degree and little plantar flexion, dorsiflexion, and give a tap on the tendoachilli and you can see the contraction of tendoachilli and plantar flexion of the ankle. Plantar flexion at ankle or plantar flexion of foot and contraction of calf muscle. Very easily elicitable. These are all the jerks elicitation. Some jerks are routinely not done like scapular, pectoral reflex, anal reflex, cremastic reflex. Those are not done. Routinely they are not done. Only in very few conditions, particularly if you want to identify the lesion at the level of damage, then it is done. If reflex is not elicitable, you ask the person to clench the teeth, and that is called reinforcement method. Jadrik's technique. Better word, reinforcement. You can see the contraction of tricep and little extension at elbow. When you want to elicit the reflexes in lower limb, you can go for this technique and then elicit. This is reinforcement technique. Or you can ask the person to clench the clench the fist. So reflex will be exaggerated because by doing that, you are increasing the tone in the muscle. So that is called reinforcement technique. Now this is another way of eliciting. So he is showing you the another way for tricep, that is in a sitting posture. You can see contraction of tricep and little extension at elbow. Now he is showing the knee jerk elicitation. This is ankle jerk. Very odd position, but don't try this technique. Very clearly. But little odd for the patient. Best is in supine posture. And I've already uploaded a video on tendon reflexes regarding the interpretation of different reflexes. Now this is a elicitation of Clonus, hyperreflexia and Hoffman sign. Voice quality is good, so in between I'll not speak.
Paul from Ortho Eval Pal, and I have with me Carmen today. Carmen comes in with a very interesting presentation.
First, he's explaining what he's going to elicit.
In one of our other offices
and
for cervical spine pain and headaches, right? You're having neck pain and headaches.
She had an injury.
Progressive loss of balance, in coordination. She's starting to shake a little bit. She also had
She's got little incoordination.
She had surgery, lost a considerable amount of weight, lost about 50 pounds over the last 2 years, and she's weighing, what, about 94 to 95 pounds right now. And, so you've gained a little bit there lately. Okay, great. And so, we started to evaluate her neck, noticed that doing cervical spine clearing and doing some neurologic testing found some unusual presentations. So what I'm going to do first is just kind of show you what we found. And then the other questions we had was, do you have a family history of MS, Lou Gehrig's disease? You haven't been out of the country, foreign country. You haven't been bit by a tick or anything like that. So nothing unusual there. So I'm going to have you relax.
He's showing you the reflexes will be brisk.
And you can see she kind of reacts. Even her her lats kind of kick in here, and she gets really kind of hyper-reflexive down in this area. It's a very unusual presentation. I'm going to check her bicep.
This is bicep.
Relax. C5.
You can see with little small tap also. This is supinator. You can see this is brisk.
Quickly she reacts there. So from there she had the same
Means
presentation on that.
Exaggerated.
Then we went down.
Now you can see the knee jerk also.
We thought we would do the lowers. Okay. And she's
This is brisk.
reactive. And notice she has kind of little clonus there with that.
Now clonus is demonstrated. This is ankle jerk.
Do her reflex, and she even develops clonus on the left side.
You can see the clonus even without stimulus.
Okay. And if I give her a little dorsiflexion,
Here you can see that.
it really fires up, and she even goes.
You can see the opposite side clonus also.
So that will calm down after a little bit. Her sensation's good, upper and lower extremities. She has a negative cervical spine compression test. She doesn't quite like extension of the cervical spine. That does give her some trouble up here.
This is because of
issues with her eyes over the last year
damage to pyramidal
We've
tract.
been dealing with that. That seems to be a little bit better now with proper glasses. So the last thing I wanted to show you is that because she has hyperreflexia and she has positive clonus, I want to make sure that
This is Hoffman Test.
So I need you to really, really relax this arm. And Andy, you might want to get in close.
You just look at thumb and finger, index finger. Just flicking the terminal. You will see that there is a
And you can see how the
index finger is going into flexion.
she's not very relaxed right
This
now,
is
but
called a
when you
Hoffman
really
Test.
relax it
It will be positive in
she
upper
has
motor
that on
neuron.
the other side also. We tried a Babinski of the foot, but but she's really ticklish, so it's really hard to see if her toes are up going or down going. But our concern right now is that she's had this loss of weight, which might have been related to the surgery. She's had some cervical spine pain, which gave her a lot of headaches.
This is the damage at the level of cervical spine.
But because of all of these other signs of
So all reflexes are exaggerated.
we need to get her over to
And
a
there is
neurologist
an
or
ankle clonus.
psychiatrist, have some testing done to make sure she doesn't have a significant cervical.
Now here he will be demonstrating again same hyperreflexia and Clonus and Hoffman sign.
Mr. Nightingale. Mr. Nightingale
This is another patient.
59 years old, comes to us today with a diagnosis of progressive weakness in this leg with some osteoarthritis in the right knee. Interestingly enough, when he's evaluated today, we find some other neurological signs and symptoms that kind of raise a red flag and indicate to us that we probably need to look into this a little bit deeper. Back in 2001, he underwent a cervical spine surgery for severe stenosis at C5, C6 and had a fusion. And
He had undergone a surgery at the cervical spine.
In his leg. So I'm not going to go through much more history than that, but I will show you some of the physical
For spinal
findings.
stenosis.
Right. So I'm going to start off with his reflexes first. And we're going to go upper for now, and then we're going to work to the more significant areas. So C7, that's a 3+, quite hyperreflexive. C5, C6. So all about 3+, equal to this side.
These are all hyperreflexia. Ideally a wrong technique. You should expose the part completely.
On the left side.
You can see knee jerk. This is hyperreflexive.
S1.
This is again ankle.
We'll be careful on this side.
Knee jerk.
Okay, so L4.
You can see the Clonus is
We
elicited.
have some Clonus in the leg.
That is patellar Clonus.
Stop it by pushing on the Golgi tendon organ just above the knee. That's a
Very nice
sign of
patellar
some
Clonus.
sort of myelopathy going on or upper motor neuron lesion. So what we'll do here is we'll gently dorsiflex him. We'll check his S1, and it actually activates his L4. He's so hyperreflexive. He's unable to dorsiflex the big toe. He's unable to dorsiflex the foot against the tone there. And his inversion and eversion are about 2+ over 5. Another very interesting finding, and we'll zoom in.
Now he's eliciting Hoffman.
Very positive Hoffman's test. So I'd like you to relax your hand. Okay. And what you do is
Flicking
you
the
hold
middle finger or a ring finger.
You flick it.
You can see
and
the
observe
flexion
the
of thumb
the
and
finger coming
index
together.
finger. This is Hoffman test.
So that's kind of like the Babinski of the upper extremity. The same thing happens on this side.
You can clearly see the finger is flexing. Very nice Hoffman test.
With that in
This is
mind,
also called Babinski of
we need to be
upper
somewhat
limb.
suspicious that he is getting
One of the sign of upper motor neuron
core
damage.
compression. And my thought is that it's in the cervical spine because he's having
Now you can see here the another demonstration of Hoffman sign.
demonstrate what that looks like. So what you do is you hold that middle finger, that
You
DIP
flick
joint.
the middle finger or ring
And what you're
finger.
going to do is watch the thumb
And you can see the
forefinger
flexion
as
of
you give
thumb
this nail
and
a flick. And it has to
index
be a
finger.
nice, real brisk flick. Okay,
You can see a flexion
see
of
that?
both thumb and finger.
So that's a
This is
positive
classical
sign. You
Hoffman
see the
sign.
fingers come together,
Classical Hoffman
just like
sign.
that. She's
Very
also
nicely
hyperreflexive
demonstrable.
on this side, and also has some tone issues in her foot and ankle, which we are going to be addressing here real soon. But
Now we'll
that's
show you
the
one
Hoffman sign.
slide
If you have
on
any questions about
what we call as Clonus. For demonstrating a Clonus, person should be in a supine posture. Flex the knee and flex at hip. Keep one hand behind the knee joint and then you dorsiflex at foot. You will see that in this. You can see small jerky movements. Can you see that? That is ankle Clonus. Upper motor neuron damage.
Similarly, patellar clonus can be demonstrated by sharply moving patella downwards. With
This is
patient
one
in
way
supine
and we have
position.
already shown you a clip. Even
is
some
mechanism
person
for
who has got
Clonus?
an increased
It is
tone,
due to inhibition of upper motor neuron
severe
system
increased
to
tone,
local stretch
knee jerk will
reflex.
be brisk, and when you tap on the
And it
patella,
can be seen in
you can
conditions like
elicit the
cerebral
patellar
palsy,
clonus, or you have to
stroke,
push
multiple
the
sclerosis,
patella
spinal
down,
cord damage, and sometimes in hepatic
and it
injury.
will be very classically
So
seen
friends,
in
this was
cerebral
all about
palsy,
Clonus. I
means condition where you got an increased tone in the muscle. In those condition, you will have, again I will repeat this.
Clonus. Now see the video.
Say clonus. Can you see small contractions? Again, stretching, doing a dorsiflexion. You will see the contraction. This is ankle clonus. Suggest upper motor
Similarly,
neuron.
patellar clonus can be demonstrated by sharply moving patella downwards with patient in supine
This is
position.
another way of demonstrating.
What is mechanism for clonus? It is due to inhibition of upper motor neuron system to local stretch reflex.
So this will be because
And
of
it can be seen
inhibition
in
of upper
conditions
motor
like
neuron
cerebral
system on the
palsy,
local reflex arc.
stroke,
And you will see that in cerebral palsy, stroke, multiple sclerosis, spinal cord damage, and also it can be seen in hepatic encephalopathy. So I end my lecture here. This was some of the clips which I could get from my YouTubes. So I have shown you those, how to demonstrate deep tendon reflexes, clonus, patellar clonus, ankle clonus, and also Hoffman's sign, which will be useful while them finding out upper motor neuron palsy. So thank you all for taking out time. I know that your time is valuable, and I appreciate you for spending some of the time with me. If you got any suggestion, you can suggest. And if you like this video lecture, please don't forget to press button like and subscribe. All these videos are mainly for educative purpose only.